our Health and Adult Social Care Scrutiny Panel for the 27th of November 2025. During the meeting, first of all, I want to thank you all for coming. I think that's very important to mention before we start. So during the meeting, all participants will be in control of your own microphone. Please ensure that you turn your microphone on when you are speaking, and remember to turn it off when you are finished. All reports published as part of the agenda will be considered as read by members of the panel. Published reports will therefore be summarized to allow the panel to focus on questions. Apologies for absence. We've got Councillor Roger Tester, Councillor Nick Williams, Councillor Sarah Jane Merrill. Do you have any other person or any other apologies received? No? Thank you. Urgent business. There is no urgent business. Declaration of interest. Does any member have any personal or financial interest to declare on this item? If there is any. Otherwise, we'll move swiftly to minutes. Agenda 4. Members are requested to confirm as accurate record the minutes of the meeting held on the 9th of October 2025. Are we happy with that? Yes, thank you. Now, agenda 5, very important. And I'm happy with this agenda because we are speaking about food. And everybody relies on food to survive. So I think ears and eyes are open wide to listen to what is going to be said. To receive an update on the work to address food inequalities and development of the borough-wide food strategy. Expected attendees, we have Samantha Bennett here, absolutely, Director of Public Health. We also have Nick Davids, not here. Okay, Nick is the Director of Health and Adult Services. Then we have our own Councillor Mariam Loliver, also Cabinet Member for Health, Adult and Social Care, and Borough of Sanctuary. I was pleased to mention that we are Borough of Sanctuary in Spain about a week ago, when I had the opportunity to address some people, and I said, we are not just looking after people, but we receive people who are running persecution. So that was said aloud for the Royal Borough of Greenwich. Then we also have Helen Butevan, not here, okay, Assistant Director of Public Health. And then we have Aiden Silk. That's right, Aiden is also Head of Public Health Programs. So all the programs, you are the head of that, isn't it? And then we have the last person, but not the least, Claire Bennett. That's right, also Senior Public Health Manager, Food and Health. You are the best person we have to be listening to, and even after this, we will definitely be finding out. So the opportunity is open to you to present, please.
Maybe Kelly could quickly introduce herself, and then maybe I'll just do a quick start and then hand over to officers.
Hi, I'm Kelly. I work in the food and health team, and I lead on food poverty.
That was just the one person who didn't have the name card, so apologies.
Oh, okay, yes. So you are most welcome. You are noted, and everybody is seeing you as well. Thank you.
So just a quick introduction, then I'll hand over to officers to take us through. So again, like you, I'm really kind of excited that we're bringing this report here today. I think we've got a really great track record of work in kind of food insecurity. I think it was at the beginning of the year, Greenwich was recognised in the Good Food London Awards, which I attended with Claire and Kelly and our previous public health director. So we were really, we're high up in that ranking and recognised for the really good work we're doing, but there's always more that we could be doing. And I think today, taking you through that kind of continuation of that work, I think hopefully allows you to see a real focus on how we can kind of tackle kind of food inequalities in Greenwich. And then I'll hand over to officers.
Thank you, Cabinet Lead, for that introduction.
Thank Thank you, Councillor Oliver. We thought we'd open our scrutiny presentation by actually inviting, and she does send her most sincere apologies, she can't join us here in person, one of our community organisations who is an organisation that really demonstrates the breadth of the food response that can be delivered with a small community organisation. So I'd like to virtually introduce Sophie Amos from Roots for Life, and after that the three of us will kind of give a little bit of a run through of where the challenges are in Greenwich, the depth of the response that we offer in terms of our food and health work and beyond with our council colleagues and the system, and also some of the emerging findings from our JSNA and steps towards the food strategy.
Yeah, thank you. We can hear from you. If you put it on for us, that's fine.
I have been asked to give a voice for the community at the forthcoming Health and Adult Social Care Scrutiny meeting. I'm sorry I can't be with you in person. A bit about Roots for Life. Roots for Life, if you haven't heard about us, we are a charity based in New Elton, Greenwich. We opened in April 2021 on the back of lockdown and the country opening up. Since then, we have welcomed over 10,000 visitors. We have a community hub with 2 kitchens, a teaching kitchen and also a community kitchen. We have 8 acres of growing land, and thanks to funding from various sources, including the Royal Borough of Greenwich, the Mayor of London, we've been able to sort of set up our food growing system. So we have a 30-foot polytunnel, which we grow our own organic vegetables in. Got a rainwater harvesting station, and we've also got various sports equipment. In terms of delivery, we have been running the Department of Education and the Royal Borough of Greenwich Holiday Food and Revival Programme for the past 5 summers. We're experienced delivery in that, providing spaces up to 32 children each day, with 4 high-level SEND places. We run a community warm hub every Wednesday with a food pantry. This provides a wraparound service with a free healthy community box. So unlike a lot of other food banks, we don't provide anything that's got high sugar content or highly processed foods. We get supplies from the Felix Project, and we ask for any vegetables and fruit. And then we also get an ambient delivery every fortnight via GBCA, the Royal Borough of Greenwich. Again, this is super helpful, particularly during the winter, because it contains soup, beans, pulses. A lot of our service users choice between heating or eating, so anything that comes in cans and can heat it up quickly is great. Our service on Wednesdays has grown significantly. We started the food bank community pantry back in 2021, and we get to 50 to 60 households. We run a free community meal every month as well, and we can get between 80 to 100 people to that. For the past few years with our warm hub, which runs from 12:30 to 3:30, we've been working closely with Live Well Greenwich, and they provide a Live Well advisor. The same advisor comes in every week and speaks to our service users and provides them with signposts and support. Predominantly our service users are in the age demographic of 60 plus. They are unemployed pensioners, likely to be living on their own, and most have multiple and complex health needs. So, for example, we have one service user who has diabetes and kidney failure, is currently going through amputation. We have several service users who suffer from anxiety and social isolation, the impact of COVID. We have, unfortunately, several of our service users have died. So we've recently had a service user attending her stroke, and we have several service users with cancer as well. We aim to provide a warm and friendly hub space. So on a Wednesday afternoon, we're 30. We provide a healthy gluten-free meal with soup. There's a little advisor to drop in and chat to, and then a community pantry. On top of that, we run an existing number of other activities. So on Mondays, we do our Green Social Prescribing Project, Green Mondays, which is currently funded by the Royal Borough of Greenwich Health Communities Fund, which is administrated by Groundworks. We also have visits from Shooters Hill Sixth Form College who come in on a Monday morning. These are 16-year-olds who might be care leavers, have difficulties adjusting to college or difficulties in their home life, and they come to us for 2 hours, and they're doing healthy cooking lessons, so learning to make a cheap takeaway, a takeaway, so learning to cook chicken in an air fry with potato wedges rather than chicken chips, and they're also doing exercise.
Go to you. Yeah.
Yes, please, Chair. We've just got a bit of a...
Oh, there's a question. Sorry, yes.
Yes, thank you, Chair. Can I ask, whereabouts in New Eltham is this based?
I know it's in
It's
Long
based in Sparrow Lane, across the road from Wyborn School.
And
So it's in Lauren, Councillor Dingsdale's ward.
yes.
Yes.
So, but whereabouts? Because there's houses in front of opposite the school. So is it run from a house?
No.
No, it's on Footscray Road, so it's quite a large hub. It's got a very large playground, and it's right next to the kind of Charlton training ground as well. So further up a little bit, yeah. Yeah, but it's a very large site, and she's always welcome to accept anyone.
Thank you. Thanks for that.
Okay, thank you, Chair. Once again, our thanks go to Sophie for making that video for us, which I hope kind of showed the depth of the challenge, but also the opportunity we have in terms of our community support in the borough. I should emphasise Sophie's organisation is obviously just one of a huge number of community food organisations, but given the breadth thereof, we felt it would be a really interesting case study to share with you this evening. So we firstly just wanted to really land where we are sitting in terms of our core strategic health and wellbeing priorities, in terms of our health and wellbeing strategy. So sitting across the 5 wells, which I know this committee is very familiar with. I'm really sorry, Nazuma, my PowerPoint skills are not good enough to get rid of an animation. So it's one of these silly slides that you just have to press the button several times to get the arrows and boxes up. So I apologise to the committee for that. But really just kind of locating, if you wouldn't mind, please. Yeah, perfect. All of them. I think it's helpful. Really just kind of picking through in terms of where, across the life course, in terms of our common, disease risk factors, unhealthy diet, physical activity, living with obesity or being overweight, very much sit across those, particularly in those big field, and they're real priorities for us from the health and wellbeing strategy in both the Be Well, in particularly the Be Well arm of the health and wellbeing strategy, and very much in terms of linking with those common causes of disease and disability, and how action to address some of those common disease risk factors can help prevent some of the impact on our population. The next slide just kind of pulls that a little bit further out. Those three disease groups account for almost 70% of deaths in Greenwich. And again, the boxes, please, Nazuma. Sorry, I think I'm saying your name wrong. I'm really sorry. Very much pick up. There's one more, I believe. Perfect. The small boxes around the side give a bit of an example of kind of what sits underneath those boxes in terms of what is impacting our residents in Greenwich. But actually, again, unhealthy diet, physical activity, obesity, overweight, smoking, tobacco use and alcohol consumption, very much sit at the heart of our prevention approach in terms of trying to reduce the disease, morbidity and mortality burden for the borough. If we look a little bit further into the challenges that we face around obesity, and we look at Year 6 obesity prevalence, so if we look, the two graphs show you obesity prevalence in both reception-age children and in year 8 and children aged in school Year 6. What we can see is that there's a big increase between reception and Year 6, and this is continuing and is a trend that we can see both nationally and within the borough. And very starkly, if you look particularly at the Year 6 figures, the relationship with deprivation, with our most deprived areas of the borough showing much higher proportion of children living with overweight and obesity. On the next slide, we look at that in terms of severe obesity. You can see again that in our ethnic minority and global majority groups, the obesity prevalence is significantly higher in both reception and in Year 6. And the other element and core point to that is very much about children living with obesity are very likely to become adults living with obesity. So really there is a real opportunity and need for us to think about how do we work with our children and young people to support this agenda. I'm going to pass to Claire now.
Thank you. So whenever we look at food poverty, food poverty is actually defined as the inability to afford or to actually have access to foods which make up a healthy diet in ways that are socially acceptable. I think this scale is really important because when we think about food poverty, the first thing that we think about is food banks, we think about crisis level, we think about experiencing hunger. But food insecurity is a scale, and it can be anything from mild food insecurity, where starting to have that worry, to starting to skip a meal or actually reducing the quality and the variety of the food of something of which is acceptable to yourself. It's a real complex and it's a multifaceted complex scenario. So then if we look at fruit and vegetables, this is national data, but we know that inequalities in food contribute to overall inequalities in health. So the recent cost of living crisis and food price increases have drawn attention to wider inequalities and access to healthy food across the population. So the most deprived fifth of adults consume less fruit and vegetables, oily fish and dietary fibre compared to the least deprived 20%. So then if we look at the key challenges for Greenwich, so our key challenges are access to healthy, safe and nutritious food. It's a key building block of health for many of our residents, but this is challenging to achieve because food, we've all got different levels of income, we cook in different ways, we've all got different cooking facilities, we all live in different houses, so having to achieve that healthy, safe and nutritious food is complicated and is hard for many people. The school health survey showed that 14% of primary school pupils didn't eat any portions of fruit or vegetables the previous day, with 10% saying that they eat some element of fast food takeaway on the way home from school. We know from national guidance that children who do eat fast takeaway food on the way home from school, they don't see that as a meal, they see that as a snack. So that could be anywhere between a 200 to a 1,200 calorie snack, and they would then go home and then eat a further meal at home. So food-related ill health is responsible for 10% of morbidity and mortality in the UK, and it costs the NHS about £6 billion annually. So those who are at most risk of ill-related health are those who live with disabilities, lower incomes, deprived areas, some from minority ethnic backgrounds, and vulnerable people such as the homeless. I've just put some stuff in there about obesity, but it's just making sure that food is wider than obesity. It's long-term conditions, it's the way we live, etc. We also know that children in deprived communities are more than 1 centimetre shorter on average than children in wealthy communities by the time they reach age 11. This can be a reflection of long-term malnutrition, and there is an increase in underweight children at year 6 as well. So if we go on to what we're actually doing to address food inequalities within Greenwich. So myself and my team, we're a very unique team in local authorities, and very few local authorities have such a team of public health nutritionists. As Councillor Lolivar said, we have been consistently in the top 3 to 4 local authorities across London, and we're identified as leaders in the food and health agenda. So this is the areas of which we work in, and we work across the whole life cycle from conception to old age. We work across all population groups. We work at both borough level, neighbourhood level. We also represent the council at both regional and national level to demonstrate our examples of good practice. Sorry, go back one. So we have a wide range of food programmes, and that's only a snapshot of what we actually do. So we oversee the Healthy Start programme. We have a network of food clubs and pantries. We roll out the Mayor's Free School Meal programme for Key Stage 2 children. We run the Holiday Meals programme. We have the Holiday Activity and Food programme. We oversee the Strategic Food Response. We have ambient food projects, infant nutrition, and we could go on, but we are a team of public health nutritionists and specialists. Next slide, please. Sorry. So this is just basically showing what the Food Response and Action Plan is in relation to food poverty. So it's where we basically link advice and support services with people experiencing food poverty. And the 3 main areas are income maximisation, food-related knowledge and skills, physical access, where we look at the food environments, and we also do provide meals for vulnerable groups. So if we start at the kind of start of the life cycle, so supporting infant nutrition, we have UNICEF Baby Friendly is identified as the kind of gold standard for supporting mothers and babies and families on their kind of infant feeding journey. Both of our children's centres and health visiting service are both fully accredited with UNICEF Baby Friendly, and our maternity services are on track to achieve that next year. We have a breastfeeding peer support service where we have trained over 30 local parents who are going onto the maternity postnatal ward and supporting women with feeding. Whether it's breastfeeding or bottle feeding, there is that support, and that has been in place for the last 18 months. It's been a successful service. They're volunteering on the ward, and they're also volunteering in people's houses and in the community. We've now had 3 of those local mums gone on to paid employment, working for the health visiting service as infant feeding specialists. We have a breast pump loan scheme, which will go live in January 2026, and that will be in partnership with with maternity, health visiting and children's services. And we also have an emergency infant feeding and infant formula pathway in place. So if we have any residents who are struggling for infant formula, we are providing that via Live Well Greenwich, and there is the wraparound support provided by our health visiting colleagues and children's services. Next slide, please. We have the Holiday Meals programme, and some of you might be aware of this, but it's been in place in the borough since 2016, and by the end of this financial year, we probably will have reached almost 100,000 meals have been provided across the borough. We have high levels of demand. We give out packed lunches, and where possible, surplus fruit and vegetables is now provided through those different sites. Next slide. We have the Holiday Food and Fun programme, so this takes place across the borough. Over the summer, we had 56 different programmes in place. I think there was almost 12,000 children, individual spaces, sorry, not children. There was 12,000 individual spaces were taken up over that holiday programme. And that has been extended by the DFE for the next 3 years. So we have pantries and food clubs, so we should ideally be trying to get away from food bank usage, and how do we try and support people into that more sustainable way of food poverty, to try and support them. So we have 6 different pantries across the borough. We've got 3 of them are delivered by Family Action, and it's funded by Public Health. We have 1 at the New Leaf Cabin, 1 at Quaggy, and 1 at Roots for Life. And this is where residents can pay roughly about anywhere between £3 to £5 a week, and in exchange they get up to £20 worth of food. So we have them. They also have wraparound support, social interaction, and they reduce social isolation as well. So there's some just headline facts there that over 66% of those people who access the Family Action Food Clubs had an annual household income of less than £10,000. So that's some headline facts there. Next slide, please. We also work in partnership with the Greenwich Food Bank, which is the largest food bank operator in the borough, and that is provided by the Trussell Trust. They distribute roughly 110 vouchers per week across all sites, which in turn supports around about 290 individuals. The main reasons for the food bank usage is financial, benefits related, it could be personal circumstances, or it could be health related as well. Next slide. Community meals, these are very popular. We have these every month where we work in partnership. We have a team of volunteers who go around month by month in different parts of the borough. We've had them at Middle Park, we've had them at, I don't know where it was this week, Hawksmoor, Clock House, Charlton. We have them and they do rotate across the borough. Where we use surplus food, we roughly have anywhere between 60 to 100 people at each meal. And there are some organisations which actually do their own meal as well, such as Roots for Life. And I think Hawksmoor Youth Club do one a month as well. So yeah, next slide. We have a cookery club, so we have quite a substantial cookery club contract where we have 60 cookery clubs delivered each year, and that's for over 600 residents. So these are 5-week programmes. We have about 35 of them are open access, and it's free for anyone to access, and they do rotate across the borough. Then we have about 35, my maths is a bit rubbish tonight, 25, where they are special provisions. So these could be for adults with learning disabilities. These could be for, we've been working with women in prisons. We've been working with a wide range of different organisations across the borough to try and give them access and how they learn how to cook and the healthy eating, etc. Next slide.
So Greenwich, this next bit's about food growing. Greenwich is active not only within our borough, but also on the national, on the London-wide scale. We're very much collaborating with other boroughs, talking with other people, shared learning, shared success. This photo was from a recent Capital Growth Network meeting, which is an offshoot of Sustain. This was drawn by residents of what they think their dream food growing environment in Greenwich would look like. You notice it's very joined up, and it kind of moves away from just the traditional community gardens in plots, and they're thinking about involving other institutions like prisons, health, GPs, schools. They're thinking of planning things they could do. And the really good thing about this meeting was we were able to talk about some of the work that is in this diagram that's already happening. Next slide, please, Nwane. So currently within RBG, there are 15 council-managed allotment sites. All of these are filled. There are 3 resident-managed allotment sites. Those are self-managed. And there are 13 total community gardens, which includes 7 small orchards, 4 gardens commissioned under the Food Environment Contract, and 2 managed by parks. There's also Get Growing Greenwich, which is a network of those involved in food growing. It's very active. We just had a meeting last week. But outside of the council, food growing takes lots of different forms. They're in GP surgeries, care homes, schools and children's centers. There is an urban farm. Their name is Zootopia. There is a pilot program happening in prisons. It's very, very early stages. Collaboration with public health, Food Behind Bars, prison team, many VCS groups. You heard of Roots for Life, but Christchurch Community Garden is holding a biodiversity working group. Metro Gavs is also doing food growing, as well as estates and resident associations and demographic-specific groups. So this activity ranges from open access to all to very specific issues or populations. But this work, along with resident engagement, has let us in the council realize that there is some work to be done with bringing all of this together within a cross-council strategic group with the aims of streamlining communications for all of these activities, thinking about setting some food growing priorities, mapping and tracking our assets, as well as encouraging further partnership working and making sure those vulnerable groups continue to be engaged. So currently we have a full draft of our food systems JSNA. This will be the first JSNA published by a local authority in the UK that looks at the entire food system rather than just food poverty. The big key recommendations are the creation of a council-chaired food partnership with a lot of council buy-in, so a governance group of council teams, stakeholders, resident involvement that leads to a borough-wide food strategy that guides our work, make sure there's resident engagement, and also creating a standardized data collection and a data collection agreement that is feasible in volunteer-based food aid service settings. I do want to note that there are a slew of other recommendations with food and health, food and culture, food and economy, food and the environment, food and the policy atmosphere that aren't listed here. They will be guided by these three main recommendations.
Sorry. Thank you both. So I hope that our presentation combined with the paper previously submitted has kind of given an indication of both the level of work that is happening in Greenwich, but also some of the challenges that we still face in addressing the inequalities in food for our population. So the next steps, as recommended by the JSNA, and as also continuing to set out our stall as one of the leaders in Food for London, is the development of a system-wide food strategy for Greenwich. Again, as Kelly has outlined, will be across the system, so we'll pick up food and environment, food and economy, food and health, food insecurity, across the system and bringing together partners and residents to develop that. With the impact being is that we very much have a much wider approach, a much comprehensive approach to our delivery of a preventative approach to food work, bringing it to be adaptable, very much led by a health equity approach, building on the work that Sam's about to tell you about, and very much led together with our stakeholders. There is an indicative timetable on the slides and in the paper, but obviously a lot of that is going to be determined by the work that we have with our residents and stakeholders to inform and develop this collectively. Thank you, Chair.
Thank you, Eden, for the holistic presentation from all your members. That was very, very thought-provoking. I will now ask panel members to ask questions if there's somebody who, yes, Councillor Spencer, to start with. Can we put that off, or do we put it for just a reason? Thank you.
Good evening. Thank you so much for this presentation. I found it really, really interesting, actually. I do have, there might be multiple questions, but on 3 different points. So the first question is on the breast pump loan scheme. I would love to know more about, I know you said that it hasn't started yet, but more about what is it, how does it help, and just sort of the goals that you guys are aiming towards. The second one is towards the holiday meals. I've seen these in the libraries, but they're always in paper bags. So I just want to know sort of what's actually in the bags, how balanced are the meals, and do you have any data on the food waste, like if the intake is, are they completely done by 12 o'clock, or are they not really getting picked up? And the last one is on the food growing initiative, especially in the prisons. I'm a councillor in West Thamesmead, which has all 3 of them. So I just wanted to know, it was kind of skimmed over, so I'm not sure if you said it's going to start soon, or has it started already. If I can get information on that, what it entails, and if there's been any interest, I would love to see that.
To answer the questions.
Perfect. So in relation to the breast pumps, this ideally is a recommendation of the Family Hub funding, so we need to implement it. It is very early days. I'm trying to remember off the top of my head because my portfolio is so big and I've been in a meeting today of every topic. So what the plan with the breast pumps is basically to help mums just continue their feeding journey. So whether they want to do mixed feeding, whether they want to express and use a bottle to provide breast milk, it will be a free of use breast pump. So it will be a fully free pump. It will be administered by the children's centres, but the family will be supported by our infant feeding specialists. There will be a full feeding assessment, and whether that family is deemed useful to have a breast pump, they will get that on loan for a minimum of 4 to 6 weeks. It will help mothers going back to work. It will just help people continue their journey. And we've also bought the same pumps as the hospital. So if someone is in neonatal care and they're using a breast pump in neonatal care, they can actually continue that use in the community. So it will be that continuity because the pump can't leave the hospital. So we've done that as much as possible. The goal is just to support mums as much as possible. These bits of equipment are quite expensive. And it's to have that whole community approach to supporting the mum. In relation to the holiday meals, the contents, they're in the paper bag because it's the scale of the provision, particularly in the Woolwich Library. So in Woolwich Library, they give out over 130 meals every day. So it's quite a big scale provision, and all 130 meals go within the first 15 to 20 minutes. It's quite big provision. Prior to COVID, it was a hot meal. But with that size of operation, we just can't go back to a hot meal in the library. It's impossible. We will be looking to going back to a hot meal in the smaller libraries and in the other community sites. But we have a sandwich, there's a piece of fruit, there's a vegetable. So it's either like a pepper or a yogurt, a pepper or a cucumber, and also a yogurt as well. So we have that. Regarding the food grown in prisons, this is very early days. We've only had meetings in the last 6 weeks. There is a charity in the prison working, it's called Food in Prisons. They currently are providing the meals for our advice hubs, which are out in the community. So do you still call them inmates? Inmates are producing the meals, and then we're actually bringing them out into the community, and we're using them as part of the advice hubs that are out in the community, really. So that is quite a new relationship, and it's something that we will hope to continue. So, yeah.
Thank you. Any further questions? Yes, Councillor St. Matthew Daniel.
Thank you, Chair. I was interested when you said that the higher in ethnic minority, global minority for poverty, is that obesity, I think you said. I mean, what would constitute that? Is that the food, do you think, or is that the way they're cooked? And how do we go about educating people on how to reduce that, please? Thank you.
I think that's quite it's quite a complex answer because the BMI centiles are actually based on 1990 centiles population data. So it doesn't necessarily take into account different ethnic groups. So that national data, that national measurement tool that we use is very much based upon different populations from 1990. I think that there are different reasons. If we look at Tower Hamlets, for example, we know that their Bangladeshi community, they have the highest rates, or they used to have the highest rates of childhood obesity. So they would then go into the community and they would spend quite a lot of time re-educating them about what can you use instead of cooking with ghee? What can you use instead of cooking with the fried food? Can you do all of that? We're starting to kind of get to the bottom of some of that and some of the insight through our weight management groups. But yeah, it's quite complicated, yeah.
Councillor McMurrow, you've got a question as well.
Thank you, Chair. Thank you for the presentation. We have a truly excellent public health team in Royal Borough of Greenwich. Could I ask you, please, what are the levers that are outside of your reach that need to be pulled on this? What messages do we have for government, for the rest of society, for other parts of government? I'm thinking perhaps of the tax system. Do we need to tax processed food and subsidise fresh food? And secondly, could you say a little bit about the joint strategic needs assessment being a whole systems approach? Thank you.
Can I suggest we take your questions in reverse order, if that's okay? Because I think also some of the challenges that we might want to put broader than Greenwich may come out of some of what we are looking at in terms of the JSNA findings. So I'm going to ask Kelly to just explain where the JSNA sits and how it sits across being a unique food systems JSNA, and then myself and or Sam will try and come in on the beginning of your first question.
Thank you. So normally when people look at food insecurity, they just focus on food poverty, so whether or not you can afford food. But this JSNA will go further. So aside from whether you can afford food, what options are available around you? What transport do you have to take? What cooking knowledge, food across the whole cycle. So from, production, how does it get to you? Is it safe when it gets to you? But then waste, what happens to the food waste? Is what's available, is it wasteful? Does it generate more waste? Are there proper mechanisms for that? It looks at education and also cultural benefits. So are we eating together? Are people isolated? Yeah.
I might jump in on the asks piece. I think one of the things that I found really interesting about working with the public health team is you do start to view things in a whole public health mindset, which I hadn't perhaps before. I think one of the things for me that's really powerful is looking at the legislation that's coming around tobacco. People will not be able to buy cigarettes going forward when they hit like a certain age, and that will change over time. And that a lot of that has been the lobbying of public health professionals and others beyond to change legislation to change the way that we interact. It does take a long time, and if you look at other areas that need it, it's gambling, alcohol, and food. We have got a sugar tax that's come in, so that's kind of welcome. But I think what is really difficult is you're kind of having to change people's relationship. As we have done with smoking, and it takes time and it takes a lot of lobbying. So, I would welcome anything that allows, but also I think there's that balance between kind of carrot and stick as well. The other thing that I think really, again, stands out for me in this is, and I think this is an exercise the team have done a while back, and I think it's often done in other councils, is that they'll do kind of a standard shop where they'll go out and buy the same set items but in different areas and look at the prices. I think when you look at that, that's what's really quite scary. Sometimes there will be certain areas that do not have many shops, that don't have much choice, and are having to use really, really expensive, smaller. So then it makes you start to think kind of to that whole systems piece. Does someone in Thamesmead have the same access to really good quality fruit and vegetables at a decent price as someone in Middle Park does? And I think that's where that inequality piece comes in. And I think the work that's being done from the JSNA really allows us to look at this from a health inequalities angle, because at the end of the day, it's not, it should, I think that stat in there that talks about certain groups being shorter, that's shocking, that you actually have certain kind of cohorts within your population who are potentially malnourished for lots of reasons, potentially, that they are not as tall as counterparts. And I think that, there's definitely a kind of call to action for anything that would be both encouraging and potentially legislating to make change, but I'll let others come in if they have anything else.
Policy-wise to think about is the cost of healthy food. So So Michael Marmot, who we obviously follow a lot, who's the health equity, health inequalities guru, he estimated that to be able to meet their healthy eating guidance, the poorest families would have to spend 70% of their income on food. So for some families, it's just not possible to be able to do it. And there's something there we know about child poverty and the efforts to kind of ensure that people have enough money to be able to just meet their basic needs, and not just their basic needs, but to try and actually live in a way that will allow them to decrease those health inequalities by getting the benefit of healthy food. I think the other thing around the food agenda, which is really interesting, similarly we've talked about smoking, but the same with food, it's absolutely that we're up against a huge marketing, massive corporations who are absolutely designed, and it's not their fault, it's what they're designed to do, is to make cash. And the easiest way to make cash around food is to deliver energy-dense, cheap food that they can sell on big scale. And that is one of the biggest challenges that we have, that is the motivation within the system. It's easy to get, it's cheaper, it fills you up, but also makes you want more of it. And so there are sort of bits in the system that are very hard sometimes for a fight. And I think it's to look at it as akin to the smoking issue about how do we change those dynamics. And I think in terms of the lobbying piece, the food industry is very similar, so that we look across the work that has been done, and it's been great about the sugar tax, and that has had a difference in consumption. And we've seen that extended to sort of the milk-based, coffee-based drinks this week to kind of continue that reach. But central government still spends a lot of time with all these big corporations as well, and how they influence them and their policy. So for us, we look at all the levers that we have locally, but, just in Greenwich, we are working against huge corporations which have that influence over that policy and how we're able to work against it. That's
Any further questions? Yes, Councillor Rents.
Thank you. That was absolutely fascinating. Thank you all for all of that work. I've got about 1 million questions, but I won't ask them all. I'm really excited to see the work you've been doing with Roots for Life and all of that work around growing, and I think there's huge potential across the borough to build on the amazing work that's going on already in depth in lots of exciting places, from Woodlands Farm and Sitopia right across the borough. I start with my corner because I know it, but there is an irony in Woodlands Farm and Sitopia being within less than several hundred yards of Greenwich Food Bank, and the inequality that brings home is quite astonishing. I know from many conversations across COVID and beyond with schools as a school governor that the issues around food waste and trying to get healthy food into children is incredibly challenging for an astonishing number of reasons, from parents' preconceptions and issues around sensitivity to texture in children, and there's a lot going on there, and it's very complicated, and it's very hard to change those habits. But I think the benefit of getting growing into schools and green spaces into school playgrounds so that the children have contact with food. I've taken special needs kids into the school allotment and watched them happily pick and eat kale, a thing I never thought I would see, before maths, first thing in the morning. And it was extraordinary how willing they were to try something completely new to them and enjoy it. It was fantastic. So I think there's massive potential for work there, and I think the stuff you've already done is really exciting. Millions more, but I will stop. The only thing I wondered was, have you looked, there's very much like a whole life approach, but have you also looked, and this may be for future, at the potential risks coming our way in terms of extreme heat, flooding? These things are relatively infrequent now, but they are getting more frequent, and they are affecting food insecurity in terms of what food is available to us as a nation. I wondered whether that's something you've looked at. It was a very long way round to the question, I'm sorry.
Earlier this year, there was a new tool published by Tim Lang in a Security Council report, I forget the name, looking at how to calculate and document imminent risk, what's imminent, what's long-term. So we have that tool. It's something, it's very long, but it is something we're looking at for the strategy work.
Any further questions? I think I will, this is an area of very good interest to me when it comes to public health because, and food in particular, as I mentioned earlier on, if this area is looked at properly, the NHS will be saving a lot of money because due to obesity and really problems that lead people to chronic conditions, the NHS is indebted into a lot because of this. So I wanted to see how your team is helping smaller groups that are there, you know, they are like voluntary organizations that are able to support people. How is Greenwich Public Health supporting them is the first question. The second question will be about the laws. It is the right of everybody to not be hungry at all and to have something to eat. We know people are at disadvantaged areas and whatnot. How are you working with other, you know, organizations like, because we speak about food insecurity, but it's linked up with people who are very, very poor. So what are we doing about linking up with getting people out of poverty and that of also even how the food is prepared, what is in the content of the food, and at the same time when the food is consumed. The law side of it was just to find out whether it is, what are we doing about people who are ordering food 2 a.m. in the morning, 3 a.m. We know these people are doing that, and people are eating around that time, and we know it doesn't help at all from the health point of view. So if you can just touch on those areas, that would be very helpful. Thank you.
Perfect. I'll take your first point first. So within my team, we have someone called Nicola Nazuza, who many of you might know, but she's been in the borough for a very long time. She runs the Open College Network training programme on how to run a cookery club. Over the past 10 years, she has trained loads of voluntary community groups with the ultimate aim of very small groups then going on to deliver their own cookery programmes and their own healthy eating programmes for their own community. So this is a skill-based course. It's an accredited course that she has been running. I can't remember the numbers off the top of my head, but she's seen loads of people go through this course. This has then resulted into very small VCS organisations having that basics, which have then gone on to enable them to run their courses. We can look at some of those organisations, like, for example, Fresh Chances, Divine Buzz down in Thamesmead. They were one of the very first organisations to go on that course, and now they've gone from delivering a cookery club to then getting large, substantial amounts of money from National Lottery. She works with Erasmus, very small community groups, and she's been training them up. She then goes and delivers mentoring programs within the community groups to then make sure that the cookery clubs are being taught properly, the messages have been taught in a safe way. So she has been doing that, and that's something that we have within the team. She continues to provide that support through the Greenwich Healthier Communities Fund. If anybody applies for any grants in relation to food, she will go out and she will provide one-to-one support, and she does all of that. So that is very much a community-based nutrition model, and she does that. Regarding the kind of Deliveroo's and everything else, I think that is such a huge challenge. I think that is a huge challenge that I don't think that's out with our control. I think it is out with our control, but I think it's such a huge issue that we do see. I know that if you ever work from home, you constantly hear Deliveroo drivers up and down the street delivering McDonald's for people's lunches and stuff, and I just think it's been a whole culture shift in the population that we've never envisaged, and that's where I think the national lobbying and the likes of the government should be putting things in place. But we try our best, but I think our hands are tied in relation to some of the work.
Any further questions? Otherwise, yes, go ahead.
Just the only thing I'd say to the point about you asking about that VCS connection, I hope now that you've seen this presentation, you'll spot public health work, particularly that food work, when you're out and about, because I think it's everywhere in the borough, and it's only when you kind of stumble on kind of a holiday, you know, that half or kind of one of our holiday meals, or you go kind of see the community meals, you'll start seeing it. Even as in my role, I went and met a shared lives carer, and he'd been on the cookery course. I saw the cookbook and I thought, oh, I recognise that. That connects into this. So I really do think kind of keep your eyes peeled. Hopefully after you've seen this now, you'll notice that work. It's kind of, it's everywhere across the whole borough. And I think all of it is kind of adding up and really contributing to making a difference.
Yeah, thanks. Definitely, this is an area that with you are giants or leaders of food strategy in London. And definitely that doesn't prevent us from learning from other people who have done things that possibly has also worked well in the form of like bank matching and then carrying on with whatever we do and doing it better for that matter. So I will say if there is any recommendation I will bring this topic to an end and we move to the next agenda. So thank you so much for your presentation and thank you. We are going to be ambassadors of speaking about how food should be, how food should be eaten and how we can support people out there. Because sometimes it's not that there's no food, but how it is even eaten and how it is distributed is also another thing, or prepared. So yes, we'll be part of that that drive to speak to residents about that. Thank you.
Can I also offer, I don't know if I'm allowed, but if anybody ever wants to come to a cookery club or anything, just let us know. Everybody's always welcome to come and look at whatever's going on. So thank you as well.
Thank you. Thank you for that as well. I think panel members would like to one day go to see, isn't it? We can arrange that. The office will arrange that for us to have. Yes. Thank you very much. Yes. Cheers. The next agenda is Agenda 6, Director of Public Health Annual Report focusing on health inequalities. To consider the Director of Public Health Annual Report focusing on health inequalities and the recommendations to the executive if necessary. So here we've got Samantha, Director of Public Health. You're here. I know Nick Davis is not around. That's fine. We have Councillor Loliver is also here. Aiden and Silk is sitting for this position as well. Support Sam, okay. And then what was the, Kelly, yes. Kelly, it is nice also having you as well. So the opportunity is for you to tell us about your annual report. Thank you.
Thank you. Sam is very much going to be presenting this as this is the Public Director's report, but I just wanted to say how excited I am that it is here today. It's a huge amount of work from Sam and a lot of people, I imagine, including those that here. And I think it kind of fits really nicely with the conversation we've just had about the inequalities that I think are in place for people around the food and how the food they eat and how they access it. And this report was very much kind of diving into that health inequalities across the borough. And it's something I think we should all be kind of basically highlighting and addressing, and it's something that I think is really key for us to be working on. I think today it's all about kind of presenting that to you, a bit of a call to arms, I think, of how we all need to be like working across the whole council to be tackling this. So without further ado, I'll pass over to Sam.
Thanks so much.
Thanks,
Nawani. Thank you. There's the first page. So, yes, as Mara said, we produce each year. The Director of Public Health is required to produce an independent report, and so this one is for our 24-25 year. So it was started by Steve Whiteman, and I think it's fair to say that it has become a labour of love / mighty tome, and has meant that it's crossed over to Directors of Public Health. But what has been really exciting about that is how it's brought us together and given us a call to action that I think is going to really direct our work over the coming years. So we've got the lovely front cover of the report there. It's been an absolute joy to see that come together and everyone's hard work to be presented in a way that really does it justice. So the main message from the report is that everyone deserves to live that healthiest life they can in Greenwich. So what we recognise through all the analysis that we've got in there that recognise where there's the variation in people's health outcomes is that I mean, we have all worked really hard to decrease health inequalities, and we have seen progress. But what we're still seeing is too many of our residents are living their lives in poor health and then dying earlier than they really should do. And it's an absolute issue of social justice. And I think that's what gets public health really going and everyone going, this is just not blooming fair. And there are things that we can do and things that we should be doing. And where we look at where those health inequalities sit, it's with our disadvantaged and marginalised communities who are the most effective. So where we've got is this real commitment to make sure that everyone has those opportunities to live their healthiest life they can, regardless of their circumstances. So we're going to go through a little bit about health inequalities, just to explain, and I know you've had the report and the cover sheet, but just the very public healthy definition that we have is that health inequalities are that unfair and avoidable and systemic differences in health. And where we see this most clearly, and sort of our headline really within the data, is about life expectancy. So that people who live in those most affluent areas have a much longer life expectancy of people than compared to who live in those areas which are ranked as being in the 20% most deprived of the country. And so people living in those poorer areas live 7 years younger, 7 years less for men, and 6.5 years less for women. And it's just not right. So when we look about health inequalities, so the diagram that we've got on the left there is just the journey and how these happen. So what we know is those wider determinants, or we're looking at calling them the building blocks of health now. So those things that set us up right from day dot and even before we're born, in terms of where we live, where we grow up, where we study, how much we earn, what our housing's like, how safe our environments feel. And if you don't have those set up in the way that support you in the way, you already start back from that starting line of life, and over the course of your life, those things kind of combine together to mean that you become less and less healthy than your peers as you go through your life. Those then really combine, and if we think about that little peachy circle at the bottom, that can mean that if you don't feel like you've got agency in your life, you don't have enough money to be able to buy the most healthy food that you could do, or exercise, or have a job that allows you to have time off to do the things that you want and to get the space in your mental health, it means that then your behavioural risks, so things that we know about such as smoking, obesity, consumption of healthy food, physical activity, drug and alcohol abuse, those things can all start building up. So not only have you got this worse start in life with the building blocks not being where they are, then your behaviours are the things that put your health at risk as well. So a lot of them combine together to then think, do you get the same access to care? So will I be able to get the care from the NHS? Will I be able to access social care? Will I be able to get care in my community that I need to? But going back to that point, if you've got an insecure job, if you're working on a 0 hours contract, if you haven't got the transport, you might not be able to access care in the same way as people who have that flexibility. So these kind of disadvantages start building on top of each other. So you get even further away from your peers in terms of where your health status is. And then in the last circle that we've got there on that quality and experience of care, because you're facing that kind of multiple levels of disadvantage, even if you get to the care, you might be experiencing different ways, which mean that you might not be benefiting it from the same way. So again, it just piles on a bit more disadvantage. So those things come together to result in differences in health status by the different groups that we're looking on the right-hand side. So that can be around socioeconomic factors. So we usually use that shorthand of deprivation about where people live, but it could be on income, education, or employment. Geography, where people live, so sometimes we look at the difference between people who live in rural areas or cities or towns. And in Greenwich, I think we really think about the access to support, healthy food, green spaces, and what that can mean in your real local neighbourhood and how that impacts on how healthy you can be. Our personal characteristics also impact and can vary between those your health inequalities. So it could be we think about those that are protected through the Equalities Act, so that could be a sex, ethnicity, or whether you've got disability. And then there's this other bigger group about our socially excluded groups. So people who experience homelessness, have got learning disabilities, could be sanctuary seekers. And what we also know is that these things can all come together at once. So it's not about putting everyone in the box that they could be from a certain ethnic group or from a certain deprivation. We have a thing called intersectionality. So these things can combine to mean that people experience worse health than they would do than if they were in one of those different groups. So where we've really got to with this is that what we're really trying to do is hardwire an equity approach in everything that we do. So this diagram tries to explain what we mean by equity. So on that top line, we've got what equality means. And I think for so long, we've been trying to think about if we treat everyone exactly the same, then hopefully that will start making a real difference to these health inequalities. But the thing is that not everyone needs the same thing. We all need different things to be able to reach that equal health. And the thing about equity is in that bottom line is that it's about tailoring responses, building those building blocks to make sure that those we fix the whole gaps in those building blocks, that we take down the barriers to good health so people have what they need to achieve those equitable outcomes for health. So go to the next slide, please. Oh, that one, thank you. So sorry that's a bit small up there, even on that big screen. But what we've got on the left were some of the examples that we pulled out on the report about some of those health inequalities. So just for example, at the top there, we've got about over half of households in Royal Greenwich face deprivation in at least one key area. But what we're showing here is on that right-hand list is about how we're doing things about it. So how is that equity approach already being applied by the council and our partners? So we know that people experiencing that deprivation, but we offer things such as the Family Hubs offers, the Greenwich Supports, Live Well Greenwich, to try and give people the advice, information and opportunities they can to get that more secure future. Or we can see there, sort of just the second one from the bottom, so one of our most vulnerable residents, such as people in those inclusion groups, such as sanctuary seekers, or people who are rough sleeping, or people who are affected by addiction, have major barriers. It's really difficult to get to healthcare when you're not in that space where that can seem the most straightforward thing in the world. So what we're doing is things like the Borough of Sanctuary status. So we're looking at safer surgeries through DentAid, making sure that there is support for people where English is not their first language, and tailoring that support so that we remove those barriers and give people what they need to get those equal health outcomes. So trying to work out what makes the difference to those people to get what they need from healthcare, and we can start closing those health inequalities. We can go to the next slide, please. So how this has kind of come together, and I think this is where we're really excited, is the equity approach. So what we've got here is what we think are our principles, but so those outside things in that grey box, and then the ingredients in the middle. So if we were to think about all the things that we could kind of put in a box about what we think we need to do to increase equity and to then decrease these health inequalities. So we're thinking about what our wider workforce. So this can't be delivered by public health alone in any way, shape or form. There's just not enough of us, despite all the amazing work that the team and all the services that work with us do. We've really got to think about how we get, our NHS partners, our partners across the council to think about what is it that people need, that treating people equally all the time is not going to get what we need for certain populations. And it's about focusing on, we don't need to change everything for everyone. So if we think that, we have uptake of immunisations is about 80%. So for 80% of the people, that process of inviting children to immunisations, they think immunisation is a great thing. We can give them an immunisation. It works for 80% of people, but it's not working for that other 20%. So what do we need to do differently to either talk about immunisations, offer it in a different way, make it accessible? And so when we're talking to GPs or an immunisation provider, how do we support them to understand those communities, to be able to change that offer to make sure that that is more accessible for those communities? So I've got a long way to go now. Let's not get too excited. So then on the other one, we've got proportionate. So this is this bit about giving people what they need. And if they need a little bit more, then we find that space to give them a little more. So we target what we can give to them. The life course, so that we focus across. So it's not somewhere where you can think about, right, we'll just concentrate on adults because, although they're already halfway through that journey, how do we make sure? We need to focus on children where we can have that impact over the long term, adults and older people. So we make sure that this is worked into our responses to every stage of life. And then on the left there, we've got about place. So we're talking a lot about neighbourhoods. And this equity approach is absolutely suited to being delivered in place, because at place we have similar groups of people who may face similar health challenges, have access or not access to similar health services or VCF, voluntary sector community support, might live in environments that are more challenging or less challenging. And so thinking about that hyper-local place-based response, you can do some of that tailoring at scale. Then in the circles in the middle of those ingredients, what are the things that we're going to do to take this equity approach? So at the top, we've got population health management. So what that's really about is looking at our data to understand who really experiences health inequalities the most, and to really understand how we who those people are, where they are, and then using what we know about our community and stakeholder engagement to really think through sort of peer research programs, thinking about how we get those insights in, to how we change our approaches for those people who have the worst health outcomes and access to health. And we think that those will mainly be those people in our purple box, which is those inclusion health groups. So how do we really focus and educate across the system, but really start focusing the care that we have to make sure that they have those chances of that additional support to have equal health. Then in that box, we've also got around community development. So we're lucky in public health to have a community development, small community development team, and we've got other community development opportunities right across the borough provided by lots of different organisations. How do we work in partnership and empower our communities? This isn't about us going out, and sometimes it feels in public health that we go through all the data and just keep telling, people how awful things are, but this is about working in partnership with communities to make sure that there's community-led decision-making and action to make it sense for communities and for them to have that opportunity to have agency in those own decisions about what really would work for them. And in the last blue circle that we've got there is the health and all policies approach. So how do we fix those building blocks? So how, within a public health point of view, do we work with our housing colleagues? How do we think about poverty? How do we think about education to get equity embedded in there? So that starts becoming a key bit, because if we get that sorted, everything else should follow. We might take a long time to be able to see the results of that, but it will come through. So the final slide there. So in terms of what we're actually doing in deliverables, so we're going to co-produce a set of priority partnership programs, so working with all of our partners, both the communities and our organisations we work with, and our voluntary community and faith sector as well, to try and think about where we can have the most measurable impact for those most at risk of health inequalities. We really want to do that collaboration with communities, public and private organisations, frontline staff and the voluntary and community sector to really work on that community-led decision-making and action so we have the best chance of making a difference. The third thing is probably the most public health thing on here. So it's a health equity toolkit. So it's thinking about that data. We've already got a dashboard up and running in terms of looking at our populations in different ways, which will allow services to look at what our population is and to compare directly whether they're seeing the people that they should be seeing, and to see if there's any gaps and how they could kind of change their service delivery to reach those people they're not reaching. We're also going to look at getting the evidence out there and, as we've got through the report, best practice and case studies about how we can have that impact. We're going to do work that are engaged with our key communities to gather more in-depth insights to see how we can make that difference. So we're thinking, at the moment, our plan is to have a peer research programme to really talk to people about what this means to them and what are the ways that we should be working with them and other organisations to make those changes. And through our own public health service, which will come into place from September, October 26th, we're asking them to collect data about their service users as part of their contract to assess that equity outcome experience and outcomes and make that as part of their contractual arrangements. They have to close those gaps. And what we've got in there, it's actually landed in my diary this week, which makes it feel really real, is the Health Equity Summit. So on March 2026, the opportunity to bring everyone together to start this off as a real programme and something that is going to be really exciting for Greenwich that we can all sign up to think how across all the things, different things that we do, how we can make a difference. And very importantly, that we'll have an evaluation of the programme and think about how that impacts on our resident outcomes at the end. So there's quite a lot going on, and we're still sort of organising it into how it looks. But I think what started off as an annual public health report has sort of turned into our mission for the next 10 years, which is both delightful and terrifying at the same time. I don't know, Aideen, Kelly, is there anything you want to add? Thanks.
Thank you for that detailed, holistic presentation. Fantastic. Do we have anybody who wants to ask a question? Panel members? Yes, Councillor Renz.
I'm interested to hear more about how you think the sort of community engagement element might work.
Yeah.
I've had a lot of conversations in my day job with NHS and their kind of plan to move towards that kind of engagement.
Yeah.
And those conversations have been very theoretical and well-meaning and exciting.
Yeah.
But as someone who works for an organisation who delivers things at the community level, I don't understand how that's going to work yet.
Yeah.
And I think that's very much the way we need to go. But clearly it's not going to be easy. And there isn't a lovely pot of money to enable us to do that. So how do we do that? And is there any scope or any use in considering something like the energy sector's priority service register system for flagging up, identifying the particular areas of risk for particular users?
Yep.
I don't quite know where that's going, but like, would something like that help to flag particular needs in cases, or is that just too complicated with health? Are there too many overlapping?
No, I think what you're kind of describing there is probably what we call that population health management bit. So we did it on a population level rather than individuals because we don't have access to that data, but there are programs that start sort of risk stratifying, and so there's things that they're doing for Greenwich Supports to look at who might be most at risk. So I guess that's the process that we kind of look for our community. So when we do all the analysis, and there's lots of it within the report, we look at what populations are most at risk. And that's not to say that every single person in that community experiences what we're, but on a kind of population level, they will be more potentially at risk from certain long-term conditions or having more risky behaviours. So in Greenwich, our biggest Black Asian multi-ethnic community is our Black African community, which is largely identified through the census as people who have got Nigerian heritage. And so we know through that there are certain things that are risk for cardiovascular disease, hypertension and under-controlled hypertension. So we know kind of from the evidence who our populations are and what might be the things that their biggest challenge or where they sort of have that biggest difference between, the population average health outcomes or access to services and what that looks like for that population. And so that's, I think, where the community engagement bit, if we can identify where the gaps are for certain groups, be it our Nepalese population or people who live in the areas of greatest deprivation, that's where you kind of start focusing that insight. And I think where we are now, it's that commitment to really working at depth with those communities to really understand. So I can kind of throw out the stats about hypertension or uncontrolled hypertension, but actually what does that mean to those communities and why does that look like that? Is that an understanding? And what then is the best way to have communication or to have those conversations or to deliver services that mean that gap that we've got at the moment, that we can close it if we can find ways to do it. So I think one of the things that we're looking at the moment is to have peer research. So we'd go out and commission organisations to be able to work within the community. So we have got a tiny pot of money for this, which is quite delightful. It's not a lot, but it's enough to start us off. So that we would then do that work, and then that becomes sort of the backbone so it gives us a bit of an instruction manual. So if we're really focused on the questions that we ask, it gives us our best chance. I think it's also about using the relationships that we've got. So we've got a number of things that kind of help us to do that engagement. And I think, what you were probably talking about is that difference between saying to people, what service do you want? Thanks very much, we'll go and have a go, or co-creating or co-producing services, which is that meaningful partnership. And it's skillful, but it's definitely within our gift. So we've got good relationships on all of our neighbourhood levels. So we've been running a programme called Connecting Greenwich for the last few years, and that's been very much about trying to work in communities and to sort of empower, working sometimes through VCS organisations, but to kind of come together to work through their own priorities and to support them to have those outcomes, but also now to be able to change that kind of conversation to the broader around some of the issues that perhaps are coming out through this and to have those discussions. And there was recently a big community meeting. I think it was in this room, actually, wasn't it? It was. Yeah, you look at the picture. And what was really heartening that came out of that those community groups representing all sorts of different communities across Greenwich, it wasn't a question about what is the council doing and what is the council not doing, but actually what can we do together? So there's, building that relationship so it becomes absolutely reciprocal and a partnership is something that we can do with small amounts of money rather than having to hand it out. I think we're lucky that we have the VCS grants programme within the council that we're just reviewing, that we can start thinking about how it supports this additionality to work with communities that perhaps don't get reached by services that we commission on big scale, but how can we work with them to support? And I think we talked about the Healthier Greenwich Fund, the Roots for Life colleague, she talked about that there are lots of different ways that people are funded, but we've somehow got to kind of get that all together to make that the sum of its parts. So, yeah, there are lots of different ways that we can put it, and it does need to be quite intentional, but I'm hopeful that we can do it. But, yeah, I think yeah, I've certainly worked where we'll engage people and you send out a survey or you ask them to come to a meeting and to feed back in. But I think we're absolutely committed to that not being what we're talking about, no matter how hard it is. Yeah.
Yeah, I think there's where you can get the knowledge and the training and the right messaging to the groups that are embedded in that community. It can be really effective with relatively small amounts of money, but a lot of those organisations are voluntary-led on minimal funding, and so sometimes to make the most of that connection, you have to support them a bit to be able to do the work you need them to do.
I think I've become very aware over the years that it can't be, there is this, habit of keep asking people and then being like, thanks very much. How do you make that meaningful part? And that often has to be that we make sure that they're funded to an extent that they are able to have that relationship with us rather than working off the back of things. So I completely agree.
Thank you.
Thanks.
For the answers as well. Do we have any further questions? I think the focus of the report is straightforward and is exciting. The area I just wanted to quickly find out is, I like the aspect of the equity approach, because health inequalities is just not acceptable at all. But unfortunately, as you mentioned, it is not just that there are health inequalities, but depending on which area you live, where you are born, and what job have you got, and even your own lifestyle and the rest. So there are so many factors. But then the question I want to see is, or want to ask is, how are you going to measure that the gap is possibly reducing by the indications and the measures that you want to put in place? And the second part of the question is about people who are really vulnerable. I know that when it comes to inequality, especially during the winter season like this, I work in the NHS and I know what people can sacrifice their food for heating. And that is very, 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 very unfortunate, especially people who are vulnerable in that matter, the elderly, the persons with disability, and people who are possibly not documented. That is also another group of people who, we have to reach out to see what is happening, because they will not come out openly for the fear of being arrested, and they could have children and even vulnerable people among them. So how do you capture that in your approach for public health in that matter? Thank you.
So I think, firstly, on the sort of measurement bit, it's one of the challenges of public health. It's quite long term. So to see that life expectancy change, we might have to wait a little while. But I think what we are able to do is that we know that there are evidence-based things that we can do that are on that journey to decreasing those big ticket item things like life expectancy or people who have developed chronic conditions. So, I was at something last week where we looked at smoking, the percentage of people who smoke. And you can absolutely see over the years where there's been different interventions around legislation and advertising and plain package and the change that smoking. It's taken time, but it has come down. So the things that we know, like smoking, levels of physical activity, obesity, immunisations, that's a lovely quick one to do, immunisations. But I love immunisations. So, you can see that difference. So it's what we do, where we know the evidence is that you can make that change. So while you might not be seeing, we will put in indicators that measure short-term and medium-term indicators, which will show that we're on the right path. And then we just have to be a bit patient for some of the long-term ones. But I think it's about, for all of these programmes and everything that we do, that we can be clear within that, what are those indicators that will tell us that we're on the right track, that evidence shows if we keep going, how will we see that difference? And you can see that difference, and there are different bits across the country that have seen drops in childhood obesity, or they have seen things change, and so I'm confident that hopefully we will be able to see those. Hopefully, I'd just like to qualify. Yeah, we will. We will see those changes, and we can see that pathway moving through. I think the bit about vulnerability, I think that's absolutely the key about the health equity approach, that it has to be reaching out, and we won't be able to do all groups at all times, but we will choose those and make sure that is that reaching out, as you described it, to those people to engage them in what they need. And it may not be that we can, you know, tick the box in terms of their indicators for those individual bits, particularly if there's people who are, you know, are undocumented, but what we can do is that we have the opportunity to do that kind of qualitative work, so that we have conversations with people and learn from those conversations and the changes that people are talking about. And I think that's important for us to think about as well.
Lastly, just to re-echo the fact that if public health does its work, then the NHS will be smiling, because the preventive part of things is absolutely something that will continue to save them a lot of money. What will you say about mental health? Because what I will also say here is a lot of people we see in the hospital is not physical reasons. There's a lot of stress now, and that is really ravaging the communities and whatnot. So how are we reaching out to prevent it before even? I think our next agenda will be speaking about mental health, but that's an area where my colleague here is so passionate about all the time. So what are you inculcating that in your public health?
Yeah, so I think mental health comes through in a couple of ways. So there's a bit that, you know, when we talk about inclusion groups, that we know that people who experience mental health challenges also have worse physical health, have a lower life expectancy, are more likely to smoke. You know, the health inequalities then pile up on that one because you have worse experiences with what you do. So there's targeted work, so that kind of reaching out to that community that we can work with. So for example, we've got smoking cessation workers that are now working within Oxley's with the Mental Health Trust to work, because I think it's about 70% of people with serious mental health issues smoke. So how do we reach out and target? How do you kind of get housing to support with people with mental health problems? So, you know, where people have already developed them, how do you support them? Or there's health checks, particularly around physical health and mental health people who are experiencing mental health difficulties. So how do we really think of that inclusion group, the challenges that they face, and think about what are those different approaches that you need to make or take to support that group? I think the bit about preventing mental health challenges is probably the bigger thing and right downstream and where public health should be. And you know, that is probably one of the biggest challenges that we face, that prevention of we know that, you know, it's endemic in our younger people, our young person population. It's a risk factor now, being a young woman, to have mental health problems, let alone anything else. And there is something about the way that we live our lives, the environments that we live in, how we prevent and promote resilience and well-being and early intervention, I think, in those childhood and teenage years, to be able to prevent that and make sure that we've got supportive environments around people so that those issues are recognised early and that people can access the support they need as early as they want. And again, taking that equity approach, that the same approach might not work for some populations as for others, so making sure that that's available in a way that suits everyone.
Yes, Councillor Rems.
Sorry, that's something you just said just sparked another question, particularly thinking about young people and the kind of multiple risks that they're facing that aren't necessarily things we've seen in previous generations. So lots of use of mobile phones and the issues around bullying and self-image and all the things that go with that. Exposure to things like vapes and the marketing and things that goes along with that. There's obviously, you know, there's a lot of connected things going on and not necessarily things that are within the council's control. But is there any thinking around what the strategy might be around that? And when you were talking about early intervention and access, how do we approach the difficulties with people getting appointments, whether that's mental health or physical health? Because the numbers of people who simply don't deal with the issues that they're facing because they know how hard it's going to be to get an appointment, or they have one and it doesn't go anywhere. And that leads to much more severe issues later on. So in strategic terms, what can we do about that? How do we approach that?
So I think that we are in an absolutely different situation in terms of our young people, in terms of what they're exposed to. So, you know, vaping, I mean, I think that's one of the things that public health feels like on our watch we let that happen. We kind of like got smoking rates down, and then, you know, absolutely vape should not have been available or promoted in the way that they should have been. And I think probably legislation will start following, as it does in smoking, to stop that access, and hope that happens sooner than later. I think the bit about the exposure to mobile phones, it's really, I was at something last week and the chief medical officer was talking about it. Everyone's been through all the evidence. There is no good evidence at the moment that phones, so for some people they're harmful, it's really mixed. For some people they're really beneficial because it allows social contact in ways that they might not have it in other ways, and for other people some bits are harmful and some bits are not. But there is clearly something about the availability of harmful material on mobile phones that needs to be prevented. So I think at the moment it is still that watchful waiting, with the sense that it's probably not a good thing for a lot of people to have access to absolutely everything. And so how do you put those kind of parameters around them? And I know that, they've tried to put dose response, think about what's the appropriate level, and, you can't do it. It's about the quality. It's what they're seeing rather than how much they're seeing. And I think that's about children and families and the supportive adults around them supporting those decisions. And it comes back to that resilience point. I think to the point about access to services, I mean, absolutely, I think it's kind of, I don't want to comment too much on my NHS colleagues. There are challenges to access, particularly around young people's mental health, but things have improved with the mental health schools team, so having that more embedded in schools. We provide, public health funds, some of the CAMS services and some of that early intervention around the youth service, but there is something about that increased accessibility or increased invisibility, or people's perceptions or faith that they're going to get what they need in the end, which is sometimes the challenge. I mean, we've been talking about that a lot recently.
I went to the Youth Council event last night, so actually I spent a lot of time asking them about health-related questions to see, and I think it's a really fair point, and I've been talking to them, is there better ways that we can connect with things that they want to cover in the Health and Wellbeing Board, and how we can explore topics together. But I think this discussion kind of really shows today how broad this can be, and I think that's what is amazing, but also somewhat overwhelming sometimes about health inequalities. It could be everything, and we could have a public health team 10 times the size and still probably not have enough people to do everything that we need to do. So I think it just shows you the breadth of the issue, both on like a national level, on a legislation policy piece, levers that we don't have control over, but also down to kind of like the individual things we're doing. So I think what's exciting about this is that taking kind of a health equity approach and having a toolkit that could empower partners, so empower our VCS, giving them access to data and like an understanding of an approach so that they can be partners with us in this delivery. I think that's the thing that I'm really excited about, and also how we embed this into the council. So for example, what I'd love to be seeing is all of our decision reports, when we're looking at that, how's this going to help improve health equity? I really think that should be a way that we're looking at things, because kind of to the point that the chair has made about, if public health do all this amazing work, think of the pressure it can save on the NHS. I think there is an element of, we're often not upstream enough dealing with the issues that as a council or as the NHS or as any other kind of like public kind of sector body is we're coming usually late. I'm not saying we can solve it all, but there's a huge ambition in this report to focus on some areas and have those, so yeah, when Sam was talking about public health cycles, it's like 10 years. So, like you saw the Sure Start publication, that was a brilliant program. And 10 years after it came out, all the results came out and you could see like it did wonders. But 10 years is a really long time sometimes. So we're going to try and get that balance of how do you show people it's working? How do you encourage people, get people excited, get them engaged, get councillors, members, VCS, business partners, all working towards an objective, but at the same time still working towards the 10-year plan as well. So yeah, hopefully I think there's something very exciting here about what we're working towards.
Yeah, thank you. Thanks, Councillor Loliver, for that presentation. Did anybody have any other further questions? Otherwise, I will say thank you very much for making a very holistic presentation of the annual report focusing on health inequalities. We cannot wait to be invited for the Equity Summit in March. I think the panel will be very much happy to take part in that. And what we've heard today will be able to unleash some of the things we can remember to make sure that this works well for everybody. Thank you all for coming. Thank you. Cheers. We now move to the seventh and the last agenda, which is commissioning of future reports. The panel is asked to note the work items that are scheduled to be presented to the meeting of the Transport and Place Scrutiny Panel taking place on the 29th of January 2026. That's next year. And thank you, happy Christmas in advance, because we might not possibly meet until January. So thank you for all what you do. And then the agenda is about age-friendly borough and also mental health vision into action. Do we agree to that? Excellent. So that brings us to the end of we don't have the public today to ask any questions. We normally give 15 minutes to them. But I think we don't have the general public today. So thank you all for coming and have a blessed evening. Yeah. Cheers.